Good evening, everyone, and welcome to this joint EUROGEN ERNICA webinar series. My name is Sara Roman, and I am one of the project managers for ERNICA. Just before I hand over to our speakers of today, I would like to take the opportunity to tell you a little bit more about the European Reference Networks, or ERNs. So the ERNs are networks of hospitals and patient organizations across Europe that work together to support patients with complex and rare diseases, as well as their families and healthcare professionals. They do this by pooling expertise, resources, and knowledge from all across Europe. The European reference networks were established by the European Commission in 2017. There are 24 of them, and each network is focused on a rare and/or complex disease area. So today, two of these European reference networks have teamed up to bring you this webinar. EUROGEN, which is the European Reference Network for Rare and Complex Urogenital Conditions, and ERNICA, the European Reference Network for Rare Inherited and Congenital Anomalies. So the webinar today is called Radiology and Motility Tests for Hirschsprung disease, and it will be presented by Associate Professor Paul Broens, a pediatric surgeon who heads the Paediatric Surgery Department at the University Medical Center in Groningen in the Netherlands, and Dr. Joost van Schuppen, a pediatric radiologist who works at the Department of Radiology and Nuclear Medicine at Amsterdam University Medical Center. The webinar will include an overview of usable and anorectal function tests and how these tests can help us diagnose Hirschsprung disease. It will also provide reasons for postoperative functional problems, and furthermore, the presentations will describe the role of imaging in the diagnosis of Hirschsprung disease. Please remember that this webinar is EACME accredited, so everyone that is following the webinar live will receive a link to a survey, and if you fill in the survey, then you will receive a certificate after 2 weeks. So without further ado, I'd like to pass the floor to our first presenter, so Professor Paul Broens, the floor is yours.
Thank you very much for the opportunity to present some of our results to a large amount of people. So I hope you can see it now.
Yes.
Yeah, perfect. So I have nothing to disclose. That's very easy. I first would start to ask with a question.
I am going to launch the poll question right now.
Perfect.
There are the results again, but only 32% of the attendees have voted.
Okay. So, fecal continence and defecation mechanisms. I would like first to explain some of the things we did do a lot of investigations in the last years about how is the mechanism of continence working, because it's very important to understand how we can improve it if you understand the mechanisms involved for fecal incontinence and defecation. So we have a few things that are important that I would like to describe today. The first one is anal sensibility. The anal canal can sense if there is content in the anal canal. It can also distinguish between flatus fluid and solid stools. It was assumed that the anal sensibility is regulated by the inferior rectal nerve, a branch of the pudendal nerve, which enters the anal canal distally and from the lateral direction through the anal canal wall. Recently, however, we published results that indicate that the anal sensibility must at least partly be regulated by nerves that follow a different route into the anal canal. The involved nerves most probably enter the anal canal from proximal bowel, intramurally from the rectum into the anal canal. The second mechanism which is important is the rectal anal inhibition reflex. When you dilate the balloon in the rectum, this will give a relaxation of the proximal part of the anal canal. And because of that, the stool can enter the anal canal and the content will be investigated. You can see in this picture downstairs, you can see then the registration of the dilation of the rectal balloon up, and you see down the reaction. There's first the contraction reflex, the rectal anal contraction reflex, followed by the relaxation reflex, and it makes possible that the stool can get into the anal canal. The next mechanism for continence is voluntary anal external sphincter contraction. Healthy people can voluntarily strongly contract their external anal sphincter. The pudendal nerve innervates this contraction. This contraction occurs only when people are actively involved in holding the stool, so not during sleeping. And this contraction can only be held for a short period. less than 1/2 minute. The next mechanism is the autonomic anal external sphincter continence reflex. There are receptors in the anal canal who are located in the anal canal who have a contact receptors that are located superficially in the subepithelium. They intervene in the continence by contraction of the external anal sphincter. And surprisingly, this is a spinal reflex, so there is no involvement of the brain. And the funny thing is that this contraction can be held for a very long period, easily more than 5 minutes, and most probably some experience they do half an hour, 1 hour without getting tired. And the voluntary contractions of the anal sphincter also initiate this autonomic contraction. So voluntary contraction is supported by the autonomic contraction of the anal external sphincter. The next mechanism is the voluntary puborectal contraction. Healthy people can voluntarily, not very strongly, contract the puborectal muscle. That's quite difficult to do that. Also, this contraction is innervated by the pudendal nerve. This contraction can only occur when the people are actively involved in holding the stool. And this contraction can only be held for a very short period, less than 1.5 minutes. The autonomic puborectal continence we found, that's another. It's also a spinal reflex located in the lower spinal cord, also without the need of the brain. And this reflex can contract very hard, which you can see on the diagram on the left. You see that the voluntary is in the upper picture, can contract, let's say, 40, 50 millimeter mercury, and the autonomic can contract 150 millimeter mercury, so much more. And also this one can contract for a very long time. You see here a control patient which easily can hold it for 5 minutes, but most probably for even much longer. So if you put these fecal continence mechanisms together, you see here a schedule that you have the anal sphincter, it has a voluntary part, and then has an involuntary, an autonomic part. And what you can understand that this voluntary part is only very short, only very few minutes a day. Actually, that is what we all know, that we don't have to think the whole day about holding our stool. Only a few minutes. When you get the sensation, then you have to help your continence by contracting. And after you have been to the toilet, you don't have to think about it, because that system is for more than 95% of the day controlling your continence, and also when you are sleeping. Then the next mechanism, what is very important, is the normal voluntary defecation. And for normal defecation, you need to increase the rectal pressure, you need to contract the rectal wall, and you have to relax the puborectal muscle and the anal sphincter. On the right side of this picture, you can see the diagram. The rectal pressure goes up and the anal pressure goes down. And because of that, you are very effectively to expel the stool. There is a very often common disease, a dysenergic defecation, where this coordination between the muscles is not working. In most cases, it is that the anal sphincter and the puborectal sphincter are contracting during defecation. And you can understand that it is very difficult to expel stool. What we did do is some studies that we could even show that is the puborectal muscle and the anal sphincter do not have to do that on the same time. But you can see that there will be sometimes only a dysenergic defecation of the puborectal muscle and the anal sphincter. That's important for the pelvic physiotherapist, because if they use a single EMG probe, they will not see this mechanism, because one goes up and one goes down. The effect what they see is that there is no contraction, which is incorrect. We could also show here in this diagram that if you have a dysenergic puborectal muscle, it is much more difficult for the body to expel the stool. You have to push much harder than when you have only a dysenergic defecation of the anal sphincter. So the effect is much more difficult. So I would like to ask you a next question. And do you have experiences in rectal manometry and other anorectal function tests in your institution? Can you tell me then the results at the end, because I can't see it?
Yes. About 70% of attendees have voted. I'm closing and sharing the results. If you're not able to see it, 41% has voted yes and 59% has voted no.
Thank you very much. The next question, what I would like to ask you, next question will be, are you interested in using anorectal manometry or other anorectal function tests in your clinical practice?
70% has voted and 75% has voted yes, 19% has voted maybe, and 6% no.
Perfect. We continue then with the next slide. I would like to describe a few of the tests that we are using for this problem. So the first one is the anal electrosensitivity test. This is a test what tells us the ability of the anal canal to sense stimuli. So what we can find that the anal canal is normally aware of anal electrical stimulation. We can find that it is diminished aware, but still they can feel something, but much less than normal. And you can find that the anal canal has no awareness of anal electrical stimulation. The second test is the anorectal pull-through and the rectoanal inhibition reflex test. So what you can measure with it is the basal anal and puborectal muscle pressure, the possibility of voluntary contraction or relaxation of the anal sphincter and the puborectal muscle, and the autonomic anal response on rectal dilatation. So what can you conclude from it is that the anal basal pressure is normal, increased, or diminished. And you can tell if the maximum voluntary squeeze pressure of the anal sphincter and the puborectal muscle is normal, increased, or diminished. And you can, of the relaxation, autonomic relaxation, you can find if the body is able to have such a relaxation, which is very important, of course, because if you do have a rectal anal inhibition reflex, then you know that it is not a disease of Hirschsprung, and it can tell you even an impression of the diameter of the rectum. I explain you later how you can do that. The next test is the balloon retention test. This is a test whereby the patient, if the patient is sitting on a commode and there is nothing under the anal channel. So the patient gets the order to keep a balloon into the rectum. And this simulates a normal continence for solid stool. So what you can conclude from it, if you are able to hold solid stool, and to give an idea, if a patient is simulating incontinence, you can easily recognize that on the recording. And it determines if the patient is aware of rectal filling sensations. The normal patients will have filling, a first sensation that they feel there is something into the rectum, constant sensation which tells that if I will be at home, I will be able to go to the toilet, or urge sensation, I will not read the last page of a very exciting book, but I will first go to the toilet and then I will finish the page. And it determines the size and the elasticity of the rectum. I will come back later on that. The last test that I will use today is the difficultometry test. It looks a little bit the same like the earlier test, that there's a little balloon into the rectum filled with 50 milliliter of water, temperature water, and you ask the patient to expel the balloon. A normal person will do that easily within 1-2 seconds. So what you can see from that, you can see if the patient is able to bring up rectal pressure, and if they can coordinate correctly an increase rectal pressure and then a release of the anal sphincter and the pelvic floor. I have a next question for the people. To exclude the diagnosis of Hirschsprung's disease, what is the correct answer?
48% has voted for the first option, 25% for the second, 27% for the third, and 0% for number 4.
Question. For the functional results of continence and defecation for children with Hirschsprung's disease, there are 2 options. Operating as early as possible, but at least within 2 months after birth is essential, or the age at which the corrective operation took place has no influence.
And again, around 70% has voted. 63% has voted for the first option, early as possible, and 37% for the second option.
We did do some research about the histology of Hirschsprung's disease on very young children. And what we could find that there is, when children are very young, there is a much higher chance that you will not be able to make a correct diagnosis. because the development of the ganglion cells and the pathologists have more difficulties with very young children than with on-age children or a little bit later. But even later, you found of older people that sometimes you will not be able to have a correct diagnosis. So also biopsies have limitations. The anorectal manometry and diagnosing Hirschprung, we learned a lot of lessons by doing it with anorectal manometry. But we found it's very important that not all newborns have a very small rectum. And if the rectal balloon dilatation is too small to touch the rectal wall, you will not see any reaction. So that's why you have to continue with small steps to enlarge the dilatation. And then you will find always first the rectal inhibition reflex, of course, if it is there. But if this reflex is not there, you will see the rectal anal contraction reflex. Once again, on the picture on the right, and you will always see first a contraction and then a relaxation. And you will also see that in patients with Hirschsprung's disease. And I did put between brackets, you don't notice discomfort in the patient, but in the reality, in practice, we did never see that. You always see before a reaction. And in practice, it means that you need 4 to 50 milliliter rectal dilatation to get a response. Here you see what very important also, that if you dilate with a little bit, that you will see a smaller relaxation than if you dilate with a larger volume. That's very important to make an objective statement that this is a normal rectal inhibitory reflex. And I show you in the second line, you see that if there is a Hirschsprung patient, you still see the rectal anal contraction reflex. And then you know that you did dilate with enough volume to contact the rectal wall. What's very important also that you have to precisely know when the dilatation have taken place, because if you do not do that, you might be confused, because in the lowest line, you see also relaxations, but these are spontaneous relaxations, and they have nothing to do with a normal coordination between the rectal wall and the anal channel. So if you would not know precisely when you did do the dilatation, you could think, okay, there is a relaxation, so therefore it is normal. No, that's not normal, that are spontaneous relaxations. So we did do a study and compared the manometry with histological rectal suction biopsies, and we could prove that we exclude Hirschsprungs with 100% the accuracy. So we do not make a mistake if we say this is a normal child. And it's very important, of course, in reversed, you will never be able to make a diagnosis Hirschsprung without histology, because it is a histological diagnosis. So you always need a biopsy, but we only do biopsies if we do not see a rectal inhibitory reflex. And also important, and I will show you later, that with the anorectal manometry, you can also find other reasons why children have severe constipation. So next to the fact that you can exclude Hirschsprung, you can also see other diseases. One of the reasons of severe constipation is overreaction of the anal continence reflex. Like I told you, in normal situations that is relaxed during the day only when something comes in the neighborhood, but some children get damaged anal mucosa, and because of that, the continence reflex is continuously firing the order to the external sphincter to contract. And you easily can see that on the anorectal manometry because you see much too high basal pressure. And because of that, then you can know, okay, this is a patient where you can inject botulinum toxin to reduce the pressure in the anal canal, and you will see a very large improvement of the patient, and they have much less problems of constipation after that. In this study, we also could show that bowel management helps also, because if you take away the stool by water, then the child does not have to push the stool out, and therefore the anal mucosa will not be damaged. Because if you see these children under narcosis, you can also see that it's kind damaged by polishing paper, that you can see some mild disturbance of the anal mucosa. And to give an answer on the question, if you really do need to do that earlier, we did a nationwide study of our patients of the last years. We have been operating in the Netherlands, And we could prove that age at surgery is no risk factor for mortality, postoperative complications, redo pull-through, and neither for functional results of constipation and fecal incontinence. So there is no urgent need to operate early, and you better can wait until the patient is out of the danger transition zone after birth. So the next step is, of course, how can you diagnose complications after surgical treatment of Hirschsprung's disease? And I will step it in two things. One, constipation. The first important thing is to understand that all children after operation for Hirschsprung's disease are always mildly constipated, because even after the operation, the rectal-anal inhibition reflex will not be there. So by definition, these children have to push a little bit harder than healthy people to get the stool out of the anal canal, because the relaxation of the proximal part of the anal sphincter is not functioning in these children. The next part, of course, that we see very often, we did do a study and we found that the severe constipated Hirschsprung children almost all had severe dysynergic defecation, which is understandable because we did operate in the earlier time in the anal canal, and probably because of the disturbance of the normal anal mucosa, these children get a mixture of their coordination of the anal sphincter and the puborectal sphincter. This is a risk for the long term, because if you are not able to get out the stool, you will get an enlargement of the rectum, and therefore at the end you will be less successful in expelling rectal content. And even in severe cases, you will get pudendal neuropathy, because you push the sphincter, the nerve, so much that after some time the nerve breaks down, and you will not be able to feel anal sensibility, and you will not be able to voluntarily squeeze your anal sphincter. The diagnosis of this dysynergic defecation can only be made if children can understand simple orders. So if like squeeze and to defecate. In practice, it means children of 7 years and older, and sometimes 6 years, they are able to do such a test, and you can very nicely explain what is the reason why they have constipation. So, of course, it is very important that the child is motivated themselves. Sometimes I make a joke that children are living in a pink cloud and they are absolutely not interested into it. And then you cannot, it is very difficult to change something of that. And sometimes you have to wait until they are older. Sometimes they are much older, 15 years. Then most of the cases, the children are very motivated in getting control over the stool because they want to go out with their friends. And then you see that the treatment for the dysynergic defecation, which is by pediatric pelvic physiotherapist, will be very successful. The point, of course, is if you cannot do it earlier to avoid that you get an enormous rectum and neuropathy, then you better can do a bowel management every day. Because of that, you will because of that, the rectum will not be filled with a lot of stool, and there will be not a lot of pressure on the pudendal nerve, and you have no risk that you will get at the end fecally incontinent. Also, if you have a dysynergic defecation, you push out the stool to a very small, narrow opening, and what you can see that then the anal mucosa gets polished, like I told you before. And you see that also with Hirschsprung patients. And because of that, you get an overreacting of the anal continence reflex. And that you can contradict by botulinum toxin. And the higher the overreaction, the more the botulinum toxin will react on that. Like I told earlier, we also showed that bowel management also helps to low down the anal basal pressure. And of course, you will have to change something of the dysynergic defecation, because if you do not correct the dysynergic defecation, this overreaction will almost certainly will come back. Because of that, the anal mucosa will again be damaged a few months later. The other direction, of course, that you can become fecally incontinent after the surgical treatment of Hirschsprung's disease. Now, as already told, dysynergic defecation, you have much more stool in the rectum. That does not have, in this mild case, have to be very seriously. You get overflow diarrhea, and also the human body is actually very clever, because if they are not thinking, controlling their pelvic floor and the anal sphincter, during walking, sporting, or dancing, you see very often that these children lose some of the stool. If they are too small to train them, then you can do bowel management to clean them. And if they are old enough to start pelvic physiotherapy, you can train them, and then this problem will be solved. Like I told you already, is the risk of the desertification, the enlargement of the rectum. Because of that, the neuropathy, pudendal neuropathy will develop. And because of that, you will become urge incontinent. So the autonomic system still works, but your voluntary system not. So it means in practice that if you have urgency to defecate, they are not able to control that. And that is because of diminished anal sensibility and diminished possibility voluntarily to contract the anal sphincter and the puborectal muscle. And also this, you can test that around 7 years old. That a pudendal neuropathy takes place, we have so far never seen that children younger than 10 years, and that's very rare. And then you have to push really very hard if you have it already on that age. You see it more often at older age. So also here, try to avoid long pressure on the pudendal nerve, because then you have, if you are over a certain limit, it is irreversible, and then the pudendal nerve will not recover. If you are on time to take away the pressure, you see that this mechanism is reversing, and then the pudendal nerve starts to react again. Also, the last one is, of course, if the autonomic reflexes will disappear. We only know that, we only have measured this after operations, because the autonomic nerve system seems to be very rigid, very strong. And the difficulty for us surgeons is that these nerves are not myelinated. So they are very small, very narrow. So it's a white line of the thick of a hair, which is running in the area. So it's very challenging not to get through it if you have no idea where to find them. So, and also to measure this, the children have to be 6, 7 years or older, otherwise you can't measure this. And so far, I'm honest, I have no idea what you can do to repair these reflexes. But luckily, we only know a very few of these patients who have that. So the take-home message for me, it is important to understand the available fecal continence and defecation mechanisms. Anorectal manometry and other functional tests can help to diagnose precise the reason why a patient has fecal incontinence or constipation. And with that information, you can make a tailored treatment plan to help this child. I have a last question. Are you, after this presentation, interested in using anorectal manometry and other function tests in your clinical practice?
Yes, and again, 70% has voted, and 78% said yes, 19% said maybe, and only 3% said no.
That's nice.
That's great.
We did do something. Of course, I don't do this research alone. I have a lot of people who are helping to do this very nice investigation. This is one of the rooms where we do this investigation on children. And the last slide, if you are interested to follow a course, you can send to this email address your name, and then we will contact you when we have a next plan. It will be somewhere in autumn of this year. And very recently, we heard that we have the healthiest and happiest city in the Netherlands. So it's always nice to be there. And the third happiest city in Europe, even.
So hi, good evening, everybody. My name is Joost van Schuppen. I'm a pediatric radiologist from Amsterdam, the Amsterdam University Medical Center. Thank you, Paul, for this excellent overview on the anorectal manometry and the other functional tests. And I don't want to brag, but I'm from Amersfoort originally, and that's actually the first happiest city in the Netherlands and Europe. And I also worked a long time in Groningen, which of course is a beautiful city as well. So and thank you for the organizing committee for actually inviting me for this to give a lecture on imaging in Hirschsprung disease. And I'm going to discuss with you the role of imaging, why we do imaging, when we do imaging, and how we actually do imaging. To start, I don't have anything to I don't have any conflicts of interest. So why do we do imaging? As Paul already told a little bit, Imaging alone cannot rule out Hirschsprung disease. So there's a gold reference standard as being pathology, either the rectal suction biopsy or the full thickness biopsy, depending on the age of the patient. And of course, as described in the prior lecture, there's a role for the anorectal function test for Hirschsprung disease. So why do we do imaging then? It can actually help establishing disease with the moderate to good sensitivity of 83 to 92% and the specificity between 74 and 97%. But of course, it can help in the differential diagnosis of the distal obstruction, so pediatric patients with distal obstruction. And once the actual disease is established, the role of imaging can also be to show the extent of the disease, so the extent of the ganglionotic colon. So when do we do imaging? Typically, we do imaging in patients with a delayed meconium passage being longer than 24 to 48 hours. And in children with signs of distal bowel obstruction, and the clinical appearance of children with distal bowel obstruction can vary quite a lot, being only constipation to distension of the abdomen, and of course the vomiting. And as already mentioned, after diagnosis is to determine the extent of the disease. So as a pediatric radiologist, we basically have two modalities that are helpful. Everybody, of course, knows the abdominal X-ray, which is the easiest way to start in patients with a distal obstruction. It's low in radiation, it's easy for patients. Next modality is the contrast enema, which gives quite the burden in radiation dose, and it's not that comfortable for patients, especially with signs of obstruction, but it's our best tool we have. So in literature, there are also articles that describe the possible role of ultrasound in Hirschsprung disease, but in my opinion and experience, it's going to be helpful to show a complete empty rectum with a small caliber, and it might even show a transition zone, but it's not helpful in the actual differential diagnosis later on. So I don't think the role of ultrasound will be that helpful. So to start with the abdominal X-ray, so the typical signs of Hirschsprung disease on an abdominal X-ray are signs of a distal obstruction, of course. And these are multiple dilated loops. So it's not only 2, 3, or 4 multiple loops, which is more a sign of an proximal obstruction, but there are multiple dilated loops. And quite typically, there is absent air in the rectum or more on the also on the left side of the abdomen. And in longer present Hirschsprung disease, there can also be signs of enteritis with thickened irregular mucosa, but that can be really hard to distinguish in dilated loops as well. So that's not a real reliable sign. So then the next modality, that's actually the contrast enema. The most important two signs on the contrast enema are actually the appearance of a transition zone and the abnormal inverted sigmoid ratio. So the transition zone has quite a high sensitivity and specificity, from 85 to 96%, and the recto-sigmoid ratio has actually a little bit lower sense and specs, as you can read. But these two items are the most important signs. And again, it's only to establish disease, it's not to rule out disease, and we'll go into that later. So in these two images on the right side, we did a contrast enema, and you can actually see that there's a change in caliber from the proximal widened loop to the more distal loops in the rectum. And if you would do a recto-sigmoid ratio, it's typically inverted lower than 1, so it will be around 0.6, which is very suggestive for Hirschsprung disease. Another sign that is also being looked at is, of course, the fasciculations in the sawtooth irregularity of the aganglionic segment, but it's lower in reliability. And signs of irregular mucosa we already discussed. So this is a next case where this is a lateral view of a patient with a signs of a distal obstruction, and we put contrast in the bowel, and you can see that there is a small irregular rectosigmoid there with the sawtooth appearance, and you can see that there is a very clear transition zone from the rectosigmoid to the descending colon, and higher up there are very dilated colon loops as well. Again, the rectum sigmoid ratio being abnormal, and the fasciculation or sawtooth irregularity of the mucosa. And this is a next patient with a longer segment of Hirschsprung, where you can actually also see contrast in the terminal part of the ileum. And you can see that there's a small ribbon-like bowel with mucosal irregularities. And if you take a good look, there's a suggestion of a transition zone in the horizontal part of the colon with more proximal dilated loops with a lot of contrast in there. So there are a couple of pitfalls when you take a look at the contrast enemas. And the pitfalls are, we know that in young patients, especially female neonates, in patients where we don't see a transition zone, we actually have false positive rates up to 48%. It's not completely clear why that is, but you might suggest if you have a uterus which is still hormonal stimulated, that might give an impression on the distal part of the rectosigmoid, but it's only a suggestion because we don't know the exact mechanism why we do have the false positives. And there are also patients where the enemas can be quite difficult, and that are the patients with the total colonic aganglionosis, where you see an example on the left side. And in this patient, you can see that the whole colon is shaped as a question mark, which is quite typical. And you have the irregular linings of the colon, and you typically see overflow of contrast in a very dilated ileum, where in other diagnoses the overflow back to the small bowel is not that clear. So here you can you won't see a transition zone, and you might suggest that there's other differential diagnosis of an unused colon, for example. Also, the ultra short segments is quite a common pitfall, and I will show you a first case. So this is a young patient with signs of distal obstruction, where we thought of Hirschsprung disease, and we put in a catheter, and we filled the rectum, and in the first filling phase it's actually okay. We don't see a real transition zone, and later on we actually filled the complete colon, which showed no transition zone. And the patient kept having complaints, and the diagnosis wasn't ruled out yet. And we repeated the enema a month after that, and we started very low, where we filled the contrast without inflating a balloon. I will get to that later. And you can actually see the small distal rectosigmoid with the transition zone higher up. So that's one of the easy ways to miss the transition zone in a short segment. And if we have the ultra short segment in approximately 3 to 4 centimeters, it's easily overlooked. So that are the pitfalls for the contrast enema. So how do you actually do a contrast enema? A part of the preparation is important, so you ask the parents or the nurses to don't do any enemas 24 hours prior to the study, to not distort the anatomy, and you keep the patient fasting for 3 hours, and that's to avoid when you put in a lot of contrast in the abdomen to avoid vomiting. So you want to make sure you're dealing with children, of course, that the temperature in the room is up, and you use warm contrast, and it's going to be water soluble contrast, and we don't use barium. And the reason why you don't use barium is when you have a child who has difficulties of evacuating stool, the barium will get impacted and give obstruction by itself as well, so that's not helpful. So how do you do it then? First, you start a catheter in the rectum, and it's really important to stress out that you don't fill a balloon in the catheter. It sounds really obvious, but still we get studies where actually they start with inflating a large balloon because they're afraid of making a lot of mess. So don't do that, of course. And you will start in the lateral position, and you start when you start filling, you also start filming, and that's to avoid if you start to film too late, you might already over distended the most distal part of the rectosigmoid. So that's really important to stress out. You directly start doing your imaging. And filling of the rectum is with a hand injection and a slow hand injection, again, to avoid missing the anatomy on the most distal part of the bowel. And the goal of this imaging is actually identification of a transition zone. And once you saw a clear transition zone, you can end the study, because you don't have other diagnoses you want to rule out if there's a clear transition zone. If there's no transition zone, you obviously try to image the whole colon to see to rule out other diagnoses in the differential diagnosis as well. So we come to the differential diagnosis. Of course, we have the meconium ileus, where you can see a case on the right side where you have a ribbon-like, very small, unused colon. And there are some impacted pellets of meconium on the right side, typically. And it's the sign of a microcolon. So this is a meconium ileus with CF. And it's really important to stress out that in the differential diagnosis, the normal sized rectum with a normal rectosigmoid is important, because that differentiates from a typical Hirschsprung disease. So this is a case of a meconium plug syndrome, which is also known as the small left hemicolon or functional immaturity of the colon. And you can see that throughout the whole colon there is stool or meconium, and the rectosigmoid ratio is normal. This is a more typical case of a small left hemicolon, which is an extent of the same disease, where you can see that on the right side of the colon there is stool or meconium, and you can actually see a transition zone on the with a smaller left hemicolon, but again with a normal ratio, and this is typically seen in patients with diabetic mothers. So important, the normal size rectum or rectosigmoid ratio is important to make the differentiation between Hirschsprung and other disease. And of course, everybody's taking a good look. I just mentioned that you should not insert or inflate a balloon. This image is, of course, at the end of the study, where the first part of the rectosigmoid was studied quite thoroughly, and at a certain point, to avoid getting that messy, you can fill a balloon with air to avoid losing all the contrast and keep on filling the baby. But again, be aware you should not use it at the start of the study. This is a patient with a typical atresia, where you have the ribbon-like colon. You don't have any overflow into the colon, into the small bowel, and it's a typical case of ileal atresia. So to my take-home messages, imaging can help in establishing Hirschsprung disease. The gold standard is the biopsy, and of course, as Paul Broens said, there's an important role for the anorectal function tests. So imaging alone cannot rule out Hirschsprung disease. It can help identify a transition zone to see the extent of the disease, and imaging is helpful in differentiating from other entities. So thank you all for your attention. I will stop sharing my screen now.
Yes, thank you so much. And now we can go on further with the discussion section of this webinar. So if Dr. Broens would also, yeah, there he is. I've also posted some questions on in the chat.
Yeah, I saw it.
Great.
There's one question: what age you can do the anorectal manometry? Actually, from 1 day of age. We have very dedicated nurses who can do that very nicely, and we don't see real problems. I will be very careful when you have a patient with ischemia, because then, of course, you might risk damage of the intestinal wall. But if that is not the case, we do from very young age, really 1-2 days, or even premature children to do manometry. And you can tell already a lot of things, not, of course, much more when they are older, because then you can also do the test when they are sitting upright, that you can see what is the continence mechanism. And that is difficult on very young children. What is my protocol for contrast enema? Oh, that's on for you, I think, Joost. You are muted.
One of the questions is, does sacral X-ray has any place in the differential diagnosis? In my opinion, it's not for a distal obstruction. It might be for abnormalities of the neural tube, but that's not for the imaging in low obstruction. Oh, so the next question is, thank you for the presentation. I would like to ask if there's any recommendations in patient with Hirschsprung associated enterocolitis. For the enterocolitis, the role of plain films and enemas is quite limited. So if you have any signs of enterocolitis, I would suggest doing an ultrasound where you can see the bowel wall thickening and a complication of the enteritis, but the plain film and enema has no role. Okay.
There's another question about high resolution anorectal manometry, what have been done, and that there was a patient of an anorectal malformation, and that could there also be Hirschsprung's disease. I've never seen a combination, a patient who has as well anorectal malformation as a Hirschsprung's disease. I know that there are case reports in it's very unlikely. Most obviously, but that's a different subject which we didn't discuss, that you can also see severe constipation after corrective operation for anorectal malformation. And I would rather think in that direction than in the direction of Hirschsprung's disease. There's another question that how to manage fecal incontinence after Hirschsprung surgery. That depends, of course. Like I told you, there are different options. If the child is very young, and I don't think it is horribly bad for the development of children if they are fecally incontinent on school. So I'm very low level, starting with bowel management if children at the age of 4 years are still fecal incontinent. And then you win time, because sometimes on that age it is difficult to find treatment like pelvic physiotherapy. And in the meanwhile, with 1 time a day bowel management, the child is clean and can function normally at school and social activities. And then if the child is old enough, you can try to solve the reason, if that is, for instance, a dyssynergic defecation by pelvic physiotherapy. Another question is, does sacral X-ray have any place in the differential diagnosis? Joost, do you want to answer that question?
I think I already answered that question. The next question is if there is the mucosal irregularity sawtoothing on the contrast tuning. Is it seen on the dilated normal part of the bowel or the HD affected collapsed segment? So it is seen in the aganglionic colonic segment, so the Hirschsprung disease segment. It's thought to be abnormal contractions of the bowel with abnormal mucosa there.
There's another question here. What are the criteria and how to diagnose of sphincter overreaction and pudendal neuropathy? Now, the sphincter overreaction you can see because then the basal pressure is very high. And that was in the old time, we had the wrong physiological idea. And then the idea was that if you have a high basal pressure, that is because of the internal sphincter. But we now know that it is the external sphincter. That's also why botulinum toxin works, because botulinum toxin gives relaxation of curve-straighted muscles and gives contraction of the smooth muscles. And so we know now that is really the external sphincter. And you see pudendal neuropathy because then the stimuli, the electrical stimuli you have to give in the anal channel to be felt by the patient goes gradually up. And normally, to give an idea, is 3-4 milliamperes, and then it gets up to 12, 16, and after 20, then it's gone. Then there is no, and that's why you can see that. And you see very soon after you see the anal sensibility going down, you see also that the possibility to voluntarily squeeze goes down. But that doesn't count for the autonomic, because that's another nerve, and you see that they still can contract autonomically.
So there's a next question on how accurate specificity and sensitivity determining the length of the aganglionic segment radiological in large bowel studies is prior to OR. So there are actually quite some recent studies which are the more retrospective kind, where the numbers are lower, but in the studies I named, for example, from Lorraine and Beltman, these are higher, and the transition zone is seen with the sensitivity between 80 and 90, and the specificity somewhat higher. So it can be helpful. And again, always when you look at studies that has been done, yeah, it can be lower in some studies, but we know that it's also quite high.
The next question is, have you seen PTNS used for fecal incontinence post-Hirschsprung surgery, and does it work? No, to be very honest, not. We didn't study that. I did study a lot of neurostimulators, and then the bad thing is that it is not really physiologically helping. Is what you do, you stimulate the afferent nerves so that you get a contraction of the muscle, and the risk is of that, because of that you get even faster pudendal neuropathy. So I'm not completely convinced if that is the good direction to go.
Okay.
Yeah, that's a very interesting question. It's in contract of interesting. Yeah, you want to answer it, Joost? Or?
No, it's. I think it's for you, because there's no radiology in there. Functional tests and biopsy results.
We have it sometimes. To be very honest, we always do a double. So that we have always also the anorectal physiology, the relaxation tests, because if you have double proof of Hirschsprung's disease, then you have more solid. We have had 2 cases who were approximately said to be Hirschsprung's disease, and then we found a functional rectal inhibitory reflex. So we said we are not going to operate it, because if it is functionally working, we do not see a ground for operation. And then in a later cytohistology, it was confirmed that it was not a Hirschsprung's disease. So we use it indeed in our institution as a double proof that it is Hirschsprung's disease. If you have as well anorectal manometry and cytohistology proof of Hirschsprung, then we start the operation.
So Paul, the last question Darren asks us, so post-operative pull-through procedure, if the patient presented with complication, any role of anorectal manometry or only contrast is beneficial for this?
Yeah, of course, because we have experience in this manometry test, because I always like to know precisely what is then the reason why. I'm with Joost. I'm absolutely agree that the pediatric radiology has an important role to see indeed the length, but the mechanism why you get an outlet obstruction is not so easy to determine on a radiology investigation. You see that there is an obstruction, but the reason of the obstruction you can, I think, not see on the radiology. And that is the advantage of the anorectal manometry, that you can see what is the reason why this obstruction is taking place. And I think that helps us to determine the best treatment for this individual patient, how to get the clinical situation improvement.
Great, thank you so much. I think it's time to close this webinar. It was very interesting. A lot of questions came in. I'm sorry if your question didn't get answered. I would like to thank everyone for joining this webinar this evening, and a big thank you to the presenters for the interesting presentations. I would like to mention that the webinar has been recorded. It will be available on our GoToWebinar platform and YouTube channel, and I will be sending the links for both of them tomorrow. You can find previous sessions on our website as well, also details for forthcoming webinars, and also on our YouTube channel, so subscribe to that. Finally, all of you who have attended today will also receive a survey immediately after the session has finished. If you would be so kind to fill that in, we can use that to continuously improve further sessions. So yeah, thank you so much, and have a good evening.